Good morning, everyone. My name is David Cohen. I'm a professor of social welfare at UCLA and the Associate Dean of the Luskin School of Public Affairs. It's my great pleasure to introduce Dr. Joanna Moncrieff, speaking to us today on myths and realities of psychiatric drugs. Dr. Moncrieff is a leading theoretician on the topic of psychiatric medication, its uses, effects, representations, and misrepresentations. And while producing a steady output of astute studies on this topic, including historical and political analyses of her own profession, I think it's fair to say that she has established herself as the world's leading critic of biological psychiatry. Dr. Moncrieff is a practicing psychiatrist and works in the National Health Service in London. She qualified as a physician in 1989, became a member of the Royal College of Psychiatrists in 1994, and 5 years later, she co-founded the Critical Psychiatry Network, which groups about 400 psychiatrists, 1/3 of which are UK-based, and she's its co-chairperson. She's also a professor of critical and social psychiatry at University College London. She's authored 3 books, including The Myth of the Chemical Cure in 2008 and The Bitterest Pills, History of Antipsychotic Drugs in 2013. Dr. Moncrieff's many observational and experimental studies in clinical psychiatry and psychopharmacology have culminated in her current role as chief investigator of the UK government-funded RADAR trial on the pros and cons of reducing antipsychotic drugs. A major publication from this trial has appeared in the Lancet Psychiatry last November. She was the lead author of the systematic umbrella review, also published last year in Molecular Psychiatry, which made waves around the world by effectively pronouncing dead the serotonin theory of depression. Her newest book, coming out in January, is called Chemically Imbalanced: The Making and Unmaking of the Serotonin Myth. Dr. Moncrieff will present during the first 45 minutes, and you can post questions on the Q&A in your Zoom, and she will try to address them during the question period to follow, which I'll moderate. Welcome, Dr. Moncrieff.
Thank you, David. Thank you. And thank you to the organisers for inviting me. It's really nice to be able to link up with David again, particularly because David helped me work out my ideas a long time ago now, at least 15 years ago, more than that, almost 20 years ago. So really credit to him for a lot of what I'm going to say today. So yes, I'm going to talk to you about myths and realities of psychiatric drugs. So just first of all, to recap where we are with them. So in the UK at the moment, 17%, so that's almost 1 in 5 of the population take an antidepressant. And the latest data show that actually it's 1 in 4, it's more than 1 in 4 women are taking them. And yet, despite this colossal use of antidepressants in particular, we seem to have a permanent and ever increasing mental health crisis. So this is just a typical headline from the last few years telling us that more and more younger people are out of work due to long-term illness, and that the main long-term illness that accounts for this is mental health problems. So what I'm going to suggest is that this situation exists at least partly because we fundamentally misunderstand what psychiatric drugs do, what their nature is, and therefore we're not and therefore we're massively overusing them. So what is our traditional medical model of treatment and disease? So I would suggest that it's this. You have symptoms that arise from a disease. The doctor identifies the nature of the disease, i.e. they make a diagnosis. A diagnosis means to identify the cause of something. The doctor can then tell you which treatments target either the disease itself, the origin of the disease, the bacteria or virus, if it's an infectious disease, or the cancer process, if it's cancer, for example. But they can also tell you which treatments target the mechanisms of the symptoms that you are experiencing, whether that's pain or breathlessness or nausea or whatever. The doctor will explain the other effects the treatments can have, the adverse effects that you might not want to have, and then you can decide whether taking the treatment makes sense or not. This is what we are led to believe psychiatric drugs do too. So we're led to believe that they correct an underlying biological abnormality of some sort that produces psychological symptoms, that they have what John Davis called in 1980 a normalizing effect. That abnormality may be suggested to be a chemical imbalance, either of serotonin or of dopamine in psychosis and schizophrenia, or it might be suggested to be an abnormality of neurogenesis, which suddenly became popular when the serotonin theory was debunked, or some other biological process. Inflammation is another one that's sometimes suggested to be relevant, or it may not be defined, it may just be assumed. And of course, this way of presenting what psychiatric drugs are and what they do has been widely promoted by the pharmaceutical industry and by professional organizations. So here's a nice little advertisement that was on a little pamphlet that was designed for doctors to give to patients in the 1990s, advertising Prozac and clearly illustrating how it was thought to work by replenishing the deficient serotonin supply. But here is a quote from the American Psychiatric Association that I looked up to check it was still there, and it was still there yesterday, telling us that differences in certain chemicals in the brain may contribute to symptoms of depression. And here's another advertisement from the pharmaceutical industry just to emphasize how much they've put on this idea of the chemical imbalance and their drugs rectifying this chemical imbalance. With the woman in the nice balanced pose here. So this idea of what psychiatric drugs do is what David and I called in our first ever paper about this, the disease-centered model of drug action. So it's the idea that drugs work by correcting some abnormal brain state, and that the therapeutic effects arise as a consequence of this. And this is indeed how most drugs work in general medicine. Even if they do not target the ultimate cause of the disease, they work on the mechanisms that produce symptoms. So, for example, the Ventolin or salbutamol in your asthma inhaler doesn't target the cause of asthma, but it targets the mechanisms that produce wheezing. So it relaxes the constricted airways and therefore reduces wheezing and breathlessness. And painkillers work in this way as well. Again, they don't target the cause of the disease, but they work on pain mechanisms to reduce pain. The trouble is, when we're thinking about psychiatric drugs or drugs that are given for mental health problems, there is another way of understanding what they might be doing, which has been forgotten about, basically, and ignored. And this is what I've called the drug-centered model of drug action. And it's the idea that far from rectifying some underlying abnormal state or mechanism, drugs themselves create an abnormal or altered brain state. They change our normal brain chemistry. And the useful effects, or the effects that are sometimes perceived as useful by some parties, are a consequence of these drug-induced changes to normal brain functioning being superimposed onto psychological symptoms, that is, onto unwanted thoughts, feelings or behaviors. So this is the way that alcohol works for social anxiety. When I was training in psychiatry, I don't know if people are still taught this, I was taught that alcohol was an effective treatment for social anxiety. No one was suggesting that it was rectifying a chemical imbalance or an alcohol deficiency. What they were pointing out by saying it was effective was that the alterations produced by alcohol include typically a state of social disinhibition, which when superimposed onto social anxiety can help to relieve it. Of course, we also have the idea that alcohol can temporarily help with depression. We have the expression of drowning your sorrows, which expresses that idea that the state of intoxication induced by alcohol temporarily obliterates underlying feelings of depression. Opiate anesthetics can also be understood to work partially in this way. They have some direct action on pain mechanisms, but unlike drugs like aspirin or paracetamol, opiates are psychoactive substances that also change the normal state of brain chemistry and brain functioning, and thereby change our normal conscious awareness and emotions. And opiates typically induce feelings of emotional indifference. And so people who've taken opiates for pain will often say that they still have some pain, but they don't care about it anymore. And that aspect of their effects is what I would call a drug-centered effect. So this drug-centered model really emphasizes that psychiatric drugs are psychoactive drugs, psychoactive substances. That is, they are drugs that change normal sensations, mental activities, cognitive functions, and behavior, as well as physical functions. The changes they induce can be pleasant or unpleasant. We normally associate the idea of a psychoactive drug with a recreational drug. By definition, recreational drugs produce effects that are pleasant for at least some people, but what I'm suggesting is there's no reason why psychoactive drugs shouldn't produce unpleasant effects. I think David actually really stressed this point to me back in the day. These changes can temporarily override mental distress or other abnormal or unwanted behavioral or mental states. But we should also remember that many psychoactive drugs cause dependence and withdrawal effects, and that they can have both predictable and unpredictable harmful effects, especially when they're used over long periods of time. Now, people have used psychoactive substances to change their states of mind for millennia, including to produce relief from depression, anxiety, and other unwanted feelings. As Aldous Huxley put it, people have often sought chemical vacations from intolerable selfhood and repulsive surroundings. This is just Hogarth's illustration of Gin Lane. And prior to the 1950s, psychiatric drugs were also understood according to a drug-centered model, often crudely as sedatives, like this advertisement for barbiturates emphasizes, or stimulants. So this advertisement for amphetamine is illustrating the stimulating effects, how it's going to make you more smart, energetic, and confident. And what we might refer to as modern psychiatric drugs, the generation that was introduced from the 1950s onwards, and that came to be known as antipsychotics and antidepressants, were initially understood also according to this drug-centered model. So chlorpromazine, the first drug that we now refer to as an antipsychotic, was introduced into psychiatry in 1952. And first of all, it was regarded as a special sort of sedative. the French psychiatrists who first used it in Paris were very excited about this drug. They thought it produced a sort of sedation that was uniquely useful in people with mental health problems. But they didn't think that it was targeting an underlying mechanism or disease. And these drugs were indeed referred to as major tranquilizers to reflect this idea, and as neurological inhibitors and neuroleptics, meaning to seize or restrict the nervous system, so similar to a neurological inhibitor. And early advertisements really emphasize this way of understanding the drugs. This is an advertisement for the drug Mellaril. This is referred to as a tranquilizer in this advertisement, but later we will see it becomes referred to as an antipsychotic. This advertisement is from 1960. Over the course of the 1960s, a change happens in thinking about these drugs, and the psychiatric community go from conceptualizing them as tranquilizers to seeing them as drugs that target an underlying disease mechanism in some way, as these quotes from early textbooks illustrate. They do more than tranquilize. They penetrate closer to the site of the mechanism of the disease than anything else that we've got. And so by 1970, you've got an advertisement with a nice psychedelic target here. It's 1970, suggesting that this drug Mellaril actually strikes promptly at target symptoms, and it's referred to as an antipsychotic. Something very similar happens with antidepressants. The first drugs that are suggested to be antidepressants are drugs that are similar to stimulants, have a stimulant profile of action. Later antidepressants aren't similar to stimulants. But initially, these drugs are described as similar to stimulants, and then they start to get distinguished from stimulants and referred to as specific treatments for depression, a specific thymoleptic, as this advertisement suggests. So what's happening over the course of the 1950s and 60s is this change from the drug-centered model to the disease-centered model of understanding how drugs work. And you can see this most clearly in how drugs are named and classified. So prior to the 1950s, there's not much interest in drugs, and they are just crudely classified, but they're classified according to the sort of changes they are thought to produce to normal consciousness, alertness, thinking, etc. So they're classified as either sedatives or stimulants. From the 1950s onwards, the drugs start to come to be classified according to the disease they are thought to treat, and they are named accordingly, so that now we talk about drugs as antipsychotics, antidepressants, anxiolytics, etc. And the point is that this transformation is not based on a whole load of evidence that discovers that these drugs actually work on underlying disease mechanisms. In fact, evidence for the disease-centered model of drug action there's never been very much of it. What might it consist of? Well, if we had independent evidence of underlying brain abnormalities that were likely to be corrected by drugs, that might be suggestive evidence. And that, of course, would include theories like the dopamine theory of schizophrenia and the serotonin theory of depression. Evidence that supposedly disease-targeting drugs had superior effects to drugs that weren't thought to target the disease mechanism might also be evidence of a disease-centered action. But even if we did have evidence of both of these things, we'd still need to somehow exclude the impact of the psychoactive effects of these drugs. Even if we had really good evidence that serotonin is involved in depression, if we are using drugs that change people's normal brain chemistry and change people's normal consciousness and emotions and thinking patterns, then we've got to somehow exclude those changes, the effects of those changes, before we can conclude that the drugs act in a disease-specific way. So is there any evidence of any of these things for psychiatric drugs? Let's think about antidepressants first. Is there evidence that they have a disease-centered action? So the idea that we understood the basis, the biological basis of depression, and that this justified, this demonstrated the mechanism targeting effect of antidepressants, was one of the main ways of justifying the idea that antidepressants might have a disease-centered action. But actually, the theories that supposedly showed that depression had a biological basis have always been theories. And as we showed in this umbrella review of the evidence on serotonin and depression that David mentioned, the evidence for the serotonin theory of depression is very weak and not convincing. And so what does this mean about antidepressants? Well, it means that we can't say that antidepressants are reversing an underlying brain abnormality or targeting an underlying biological mechanism that produces depression or the symptoms of depression. There may, of course, be other biological mechanisms apart from serotonin, and there are numerous other theories. After we published this paper, someone put up a table on Twitter that had something like 39 other theories that have come in and out of fashion over the last few decades, and there are more. But the point is, these have not been established either. These all remain as theories, and very likely the evidence for them is as weak as the serotonin theory of depression. Do antidepressants have superior effects to drugs that are not considered to be antidepressants? Well, one rather strange thing is that antidepressants come from all sorts of different chemical classes and have numerous different actions on brain chemistry and brain functions. But it turns out that many drugs that are not conventionally considered to be antidepressants do as well in randomized controlled trials in people with depression as antidepressants do, including antipsychotics, including Purple Hearts. They were a combination of amphetamines and barbiturates, including amphetamines and other stimulants on their own, barbiturates on their own, benzodiazepines, opiates, the list goes on. In fact, it seems like almost any psychoactive substance that has been tested in depression turns up as being effective in one trial or another. What about antipsychotics? Is there evidence that antipsychotics have a disease-targeting effect or a disease-centered effect? Well, of course, we have the dopamine hypothesis of schizophrenia and psychosis, which suggests that schizophrenia or psychosis may be due to overactivity of dopamine, or as it's often euphemistically put, dopamine dysregulation, when people don't want to specify whether it's actually overactivity or underactivity. And of course, because many antipsychotics do target dopamine, that's then thought to confirm that they have this disease-targeting action. But as it happens, not all antipsychotics primarily affect dopamine. In fact, some very effective antipsychotics, such as clozapine, do not have their primary effects on the dopamine system. And many antipsychotics drugs affect many other chemicals other than dopamine, even if they do affect the dopamine system. Other bits of evidence that were considered to support the dopamine theory of schizophrenia are also lacking or inconsistent. It was one bit of evidence that was often said to support it was the fact that stimulant drugs can induce a psychosis, and stimulants are known to affect dopamine. But dopamine abnormalities are not known to be the cause of stimulant-induced psychosis. And stimulants do affect dopamine, but also affect many other brain chemicals, including noradrenaline, for example, and it's not been demonstrated that it's their specific effects on dopamine that cause that are the cause of stimulant-induced psychosis. Measures of dopamine itself and dopamine receptors in people with schizophrenia or psychosis are either negative, i.e. no different from people without those diagnoses, or have been shown to be induced by drug treatment. And then other indirect studies of dopamine activity, such as L-DOPA uptake, are inconsistent and confounded by stress, arousal, and movement, because dopamine is something that is released when someone is agitated, stressed, aroused, hungry, moving a lot, etc. Okay, I'm just going to move on to that. What about, are antipsychotics better than other sedative drugs, for example, that might have beneficial effects in psychosis and schizophrenia? Well, there are some old studies that compared antipsychotics with barbiturates, and they did seem to suggest that antipsychotics were superior. But in fact, other comparisons with opiates and benzodiazepines and with lithium have not found that antipsychotics were superior, although the caveat is that this evidence is pretty old and there are lots of limitations to it. The lithium studies found that antipsychotics were better for people who were highly overactive, but no different for people who were just moderately ill. A more recent study has looked at barbiturates and benzodiazepines in particular and found superior effects to barbiturates, but no difference and very little. They looked at very little evidence for the benzodiazepines. But as David and I pointed out in a response to this paper, it may well be that antipsychotics are superior to some other sedatives like barbiturates and benzodiazepines because of the particular nature of the sedation that they produce, which, as was pointed out by the Parisian psychiatrists who first used them back in the 1950s, consists of a dampening of emotions and a dampening of cognitive processes without just sending people to sleep and making people drowsy and dopey as barbiturates and benzodiazepines do. Before we leave this topic, what about lithium? Because lithium is often highlighted as the sort of paradigmatic example of a specific psychiatric drug that targets a specific disorder, and presumably by targeting the underlying mechanism, although no one quite knows what that is, although there are plenty of theories, of course. There are actually two quite good studies that tried to look at whether lithium had specific effects and compared lithium to antipsychotics in people with different presentations of psychosis or mania. Neither found that lithium was specific for people who had affective symptoms or manic presentations. Both found that antipsychotics and lithium were exactly the same for people who were moderately disturbed or distressed, but that lithium was inferior for the management of people who were severely disturbed because it's so toxic. And this was also found in a large study of the treatment of mania, that lithium was the same as antipsychotics when people were moderately ill, but really not very effective if people were more severely ill. So I hope I've managed to convince some of you maybe that the disease-centered model is the wrong way to think about psychiatric drugs. And I just want to spend the rest of my time thinking about what it means to adopt a drug-centered way of thinking about psychiatric drug treatment. So the first thing is that we need to know a lot more than we currently know about what psychiatric drugs do to the body and particularly to the brain, and how they affect, how they change mental and behavioral processes and functions in the short term, in the long term, after withdrawal, whether there are any persistent changes. And shocking as it should sound, I hope, we really don't know very much about this because we have been so focused on the idea that what they're doing is targeting this particular dopamine receptor or this particular serotonin receptor. So the evidence that we have about the sort of mental changes that are caused by different drugs comes indirectly from it comes from some animal studies, from some volunteer studies, and then indirectly from studies of patient reports. And we probably have most evidence about the changes produced by antipsychotics because the people who used them early on still had that drug-centered way of thinking about antipsychotics and were still interested in the sort of changes they produced. So the evidence suggests that antipsychotics produce sedation, mental slowness, cognitive impairment, but particularly that they have this quality of producing emotional blunting and loss of interest and loss of motivation and initiative that's been replicated in many and described very vividly in lots of volunteer studies. I think it's nicely summed up by this cartoon by someone who calls herself Auntie Psychiatry, who contrasts the excitement and danger of psychosis to the grey normality that is induced by taking antipsychotics. And Oliver Sacks, the famous neurologist's brother, who had schizophrenia and took antipsychotics for it, described the antipsychotic-induced state as feeling rottenly normal. Antipsychotics also produce lots of physical adverse effects. Recent evidence has suggested they cause brain shrinkage. That comes from animal studies as well as human studies now, and lots of other adverse effects that I'm sure you're aware of. So this is the reason why myself and several other groups have got funding to look at antipsychotic reduction studies, because it is increasingly acknowledged that these drugs do have serious adverse effects and should not be used unless they're really necessary. So all these studies are antipsychotic reduction studies. And they were all the funding for these studies was boosted by the first of these, which was the Mephisos studies in the Netherlands, which was a study of first episode psychosis patients, which found that in the long term, people who had a gradual reduction of antipsychotics did better in terms of their functioning, were more likely to show an improvement in functioning and recovery than people who were randomized to continue on maintenance treatment. So I'll just give you the results of the radar study very quickly that David mentioned. So we conducted a similar gradual reduction of antipsychotics compared to maintenance treatment. We looked at people who had recurrent episodes of psychosis rather than just a first episode like the Mephisos study. Our main outcome was social functioning at 2 years. We found there was no difference in social functioning at 2 years. That was a bit disappointing, but quite similar to the Dutch study, which found no benefit of their antipsychotic reduction at their initial follow-up. They looked at 18-month follow-up. And we're doing a longer term study to see if there are any benefits in the long term. Like them, we also found that people were more likely to relapse if they had their antipsychotic reduced than if they continued on maintenance treatment. But the majority of people who stopped their antipsychotics completely or who reduced by 50% did not, in fact, relapse. About a third of them relapsed, about 2/3 of them didn't relapse. So although relapse is more of a risk if you reduce your antipsychotic medication, at least in the short term. It is not inevitable. And in the qualitative study, sorry, my slides keep getting out of sync. In the qualitative study, many participants described how they felt that they had benefited from antipsychotic reduction, either because they were glad to have had a go and maybe to have learned that they needed medication, or because they'd experienced an improvement in their functioning and a reduction in symptoms, in adverse effects. We've just done an analysis of relapse, which we've submitted for publication, but hasn't been accepted yet. And this shows that among people who relapsed, people who relapsed returned to their baseline levels of symptoms and functioning at the 2-year follow-up. So it didn't look as if relapse had any permanent detrimental effects. So this is the baseline social functioning, baseline blue, follow-up red in people who relapsed, and compared to people who didn't relapse, and symptoms again. So that's reassuring, I think, for people. So we're doing a long-term follow-up, and we'll report on that in a year or two. But from the first phase of the radar study, we can say that reducing your antipsychotic medication does increase your risk of relapse in the short term. And we did look at, we evaluated relapse very stringently. So I'm confident that this wasn't just a sort of blip or withdrawal symptoms. And in the short term doesn't give you any benefits in your social functioning overall anyway, although some participants felt it had been beneficial. But relapse was not inevitable, and the majority of people actually, even if they reduced their medication, did not relapse. So just for the last few minutes, I want to think about what a drug-centered understanding of antidepressants means, and then I'll close and we can have some discussion. So as with antipsychotics, the first thing we need to think about is what sort of physical and mental alterations do antidepressants produce. Then we need to think about whether these might be helpful in people with depression. But particularly for depression, we've also got to factor in placebo effects and how these might affect the research findings. As I suggested earlier, antidepressants come from many different chemical classes, so they have a whole range of, they produce a range of quite diverse changes in alertness, arousal, consciousness, mental acuity, and emotions. Most of them, or many of them, do seem to have this quality of producing some sort of emotional blunting. I would say nowhere near as dramatic as antipsychotics produce, but a more subtle effect described by one person in one study we did as feeling distanced from life. And this emotional effect, at least for some of the antidepressants, is associated with sexual dysfunction. And has been shown in one study with volunteers, although not investigated in other studies that I know of. So the question is, how might these changes impact on people with depression? The emotional blunting, of course, might reduce people's depression scores. Sedative effects of some antidepressants might help with insomnia or agitation, but other effects like lethargy and weight gain might make people feel worse. And crucially, the alterations might also unblind randomized controlled trials so that you may get amplified placebo effects in people who are taking the antidepressants. Overall, antidepressant trials show only very small differences between antidepressants and placebo, about 2 points on the Hamilton rating scale for depression. So that's the difference between these two blocks. Baseline levels of depression are usually around 30, this block, and the total Hamilton score is 54 points. Almost every way of measuring the clinical significance of antidepressant effect suggests that a 2-point difference is not clinically significant. On top of this, it's highly likely that this difference is at least partially caused by unblinding effects. When trials investigate whether they are really double-blind, whether people can guess what they're taking, most trials find that people can, not all, but most trials find that people can correctly identify better than would be predicted by chance whether they've been allocated to the drug or the placebo. And I recently was involved in a group who did an analysis of the TAD study, which was a comparison of fluoxetine and placebo in adolescents with depression, which asked people to guess at 6 weeks and 12 weeks and measured outcome at 12 weeks. Asked people to guess whether they were on the drug or the placebo. And we showed that the people's guess at 6 weeks affected people's outcome at 12 weeks. So people who guessed they were on fluoxetine, that's everyone who guesses they're on fluoxetine, has a much better outcome than people who guess they're on the placebo, regardless of what they're actually randomized to. So the people who are actually on placebo but guess they're on fluoxetine are the group that actually do the best, have the best outcome. And then the interesting thing was that the guess had a statistically significant effect on outcome at 12 weeks when you controlled for other factors like the baseline score, age at baseline, and treatment allocation. That's whether someone is actually on placebo or fluoxetine. When you remove guess from that analysis, the treatment allocation becomes almost statistically significant. Okay, it becomes much stronger. So what we're finding is that the effect of the treatment allocation is basically being confounded by people's guess of what they're taking. And there are lots of other studies that also show really strong effects of expectancy on outcomes in depression. What's this? Other non-randomized controlled trial evidence on long-term outcomes of antidepressants is also not promising. Almost every study that compares people who take antidepressants with people who don't in a naturalistic fashion shows that people who take antidepressants do worse, even when you control for baseline levels of depression. The STAR-D study, which was this large naturalistic study of antidepressants, found completely abysmal outcomes. In fact, a secondary analysis by Ed Piggott showed that only 3% of people, of the 4,000 people who entered that study, remained in the study and remained well. So I'm trying to convince you that antidepressants have minimal, if any, benefits on depression. A lot of people say that modern antidepressants don't have terribly significant adverse effects, so maybe that doesn't matter too much if they're just having placebo effects. But there's increasing evidence that they do have some serious and relatively common adverse effects, which include serious withdrawal symptoms, which can last sometimes for months and years, and sexual dysfunction, which is recognized as being common when people are taking antidepressant medication. But there is increasing evidence that some people experience sexual dysfunction after they stop taking the antidepressants, sometimes for months and years afterwards. This is something that really, really needs to be highlighted to people, and you know, something that I feel psychiatrists are not taking seriously enough. So what have I been saying? Really, that the drugs prescribed for mental disorders do not reverse or target an underlying disease or abnormality, or even an underlying mechanism of a symptom. they alter our normal brain chemistry and the way that our brains function in ways that we do not fully understand. And because of this, they have unpredictable and under-researched adverse effects, especially after people have been using them for long periods of time, which many people are. Many people take these drugs for years at a time. These alterations interact with mental symptoms in various ways. There's little evidence, in my mind, of net benefit for the use of drugs for common psychological complaints, such as depression and anxiety, particularly long-term continuous use. But I think there are arguments for the use of antipsychotics for the suppression of acute and ongoing psychotic symptoms. But we also have to acknowledge that antipsychotics have a high burden of adverse effects, and that we need to keep their use to a minimum too. So some psychiatric drugs can be useful in some situations, but we fundamentally misunderstand what they do, is the take-home message. Those are my conflicts of interest, and those are my recent books. Okay, thank you very much. Thanks for listening. Hope I've left enough time for discussion.
There's some time. Thank you so much, Joanna Moncrieff, for this presentation. And I don't see questions in the Q&A, and I'm looking in the Q&A and the chat. So how about if I just ask you a question to get this going? We still have a good 10 minutes at least, I think. So my first question might be, you've discussed the placebo effects a lot. You've mentioned the drugs as amplifying placebos in trials. You've mentioned the guesses that people who make about being on placebos, how they might be confounded with the allocation to the treatment, and maybe even overwhelm that allocation in a sense. And the question I have for you is, given that some people have called antidepressants placebos with brand names sometimes, what is your view on the use of placebos in some form or other in the clinical setting, acknowledged or somehow nicely camouflaged or so? What is your view on that, given some of these findings you presented?
That's a really good question, David. So I think we need to unpick the placebo effect a little bit and try and understand what's going on. And actually talking to some people for my recent books and people who've been on antidepressants recently, really started to delve into what these effects consist of. So many people said to me that when they were told they had a chemical imbalance and, there was a treatment for it, they initially felt a bit of a buzz, I think someone said. They felt, oh, wow, great, there's an answer. And they felt good. And they started taking the drugs. And then this idea that they had something wrong with their brain started to actually become quite a depressing idea. And when some of them didn't really feel very much better on the drugs, it became even more depressing, because then they thought, oh my goodness, I've got a broken brain that isn't even responding to the treatment. Where does that leave me? Leaves me as a, completely defective human being. So I think that's one way in which placebo effects can be harmful, because because the message of a pill is for most people that there's something wrong with your brain, and that you can't rectify it on your own. You need this pill to put it right. So I think in the short term, the placebo effect can be a boost, can improve outcomes. In the long term, I think it potentially makes outcomes worse. And I think it may be one of the reasons why the long-term effects of antidepressants look so dismal. I mean, we don't have many really good long-term studies. I think you did a systematic review, didn't you, David, of
Yes.
Of long-term antidepressant studies. They don't look very encouraging at all, is my overview of them.
That's correct. That's correct. Thank you for your answer on this. I have another question also. Looking at your work, looking at the regular pronouncements from really respected, the highest authorities in the field of psychiatry, whether it's Thomas and Semel, who says we're just not, we don't see the improvements that would sustain us calling the field, progressive, in the sense that we're making progress. That there are more suicides, hospitalizations haven't decreased, relapses are still as common, and all these things. We have the head of the DSM-5 task force way back when in 2013 said we don't have the biomarkers, so we kind of, deceive patients. And we see these pronouncements on a regular basis every 5-10 years of reviews of the evidence, whether it's neuroimaging, providing no mechanistic account whatsoever for any psychiatric condition. So my question is, do you think the case has been made that let's call it the biological approach to mental illness, to mental disorders, has been a failure, or it still deserves the massive investment it continues to get? Or is or no, it's still an open question, and the status quo should continue, or maybe some third option?
No, I absolutely think we should stop. I mean, when do you draw a line? Surely we should have drawn a line a long time ago, instead of, I feel that we're just banging our heads against a brick wall. We obviously we can't go, we could go on. I mean, the problem is we could go on and on and on looking for things. We could, because you can never prove a negative. You can never finally say there is nothing. There will always be something else to look at. So surely we need to look back on now 70 years of trying and, having got nowhere, and say enough is enough. That's my view. Which doesn't mean, I'm trying to say that I do think there are some uses of psychiatric drugs. So it doesn't mean we abandon biology altogether, because we need to know what those drugs do to people's biology. But I think the search for the biological causes of mental health problems, yes, we ought to draw a line.
Here's well said. Here's a question from someone, Gregory Barnett. How does your research and data impact your own prescribing practice, particularly when it comes to depression, anxiety, and for those who have not responded to therapy?
So that's a really good question. And I've recently joined a new team where I work, and I'm seeing a lot more people with depression and anxiety. I hadn't done that sort of work for a while, but have been doing so for the last 18 months. So I get asked to see a lot of people by general practitioners who are either thinking about starting on antidepressants or have been on an antidepressant and it doesn't work, more commonly, and some who have had therapy too and feel that hasn't worked. I mean, what I do is I explain to people that there are drugs called antidepressants. Most doctors would recommend them in your situation. This is what they do. They numb your emotions a bit. They suppress your sexual functioning. They have these other adverse effects, and there are these other risks involved in taking them. The evidence that they will actually be beneficial is really pretty slim. But most doctors would offer them. So if you would like to take them, given this information, then that's fine. And I would recommend usually fluoxetine, because I think it's easiest to get off and has the best side effect profile. Let's start it and let's monitor it carefully and make sure you just don't end up on it because no one wants to take you off. So that's one response I have. For people who are thinking about starting them and want to start an antidepressant. But I suppose my main thing is that I try and explain to people that depression is not a chemical imbalance. We have no evidence that it's something wrong with your brain. That therefore the best way to understand depression, in my view, is to see it as a response to things that are going wrong in your life that you may not have been aware, you may not be aware of. Sometimes therapy can help people to work out what those things are. but not always. Sometimes it's about sometimes it's about resolving relationship problems, work problems. Sometimes it's about trying to find a new purpose in life. And I try and help people to see their problems in a different way. And sometimes I say to people that actually I don't think medicine can help their situation. And that I don't necessarily have an answer for them. And I know that as a doctor, there's a real temptation to solve people's problems, to offer people a treatment. I really am really am convinced now that is not necessarily the right thing to do. And that it may be the right thing to do to say to people sometimes, actually, there isn't a medical treatment out there for your situation. I can't help you. I'm sorry about that, but I can't help you. Maybe a social worker can, maybe a therapist can, but this is not the right place for you.
Thank you. Here's a recent question that's just come up now. We have about 4 or 5 questions. Let's see, maybe you could answer briefly, maybe not. What's your take on psychotherapeutic individual and family approaches, I think, as it relates to the treatment of schizophrenia or psychosis?
I suppose I think they're useful for some people and not for others. I mean, I know people with psychosis who would find it very difficult to engage in therapy. But I know people for whom, for whom therapy has been very useful. So yeah, I think that's my answer to that. Do you want me to run through other questions quickly? There was one about the radar.
Oh, you see them. Yes.
Yeah, yes, I can see them. There was one about the radar. So a severe relapse was defined as a relapse that required admission to hospital. And that was our main safety outcome. And then another part of that question, aren't there data suggesting that antidepressant episodes are greater in study participants than more severe? Okay. So the data that suggests that antidepressant placebo differences are greater in people with more severe baseline depression is pretty slim too. So the very large study, an FDA data analysis by Stone et al., published in 2022, I think, showed that there was a very small effect of baseline severity, but the difference between placebo and antidepressants was still very small. Still, I think it was maybe just above 2 points, but not much. And the actual effect of baseline severity was not very strong. There have been some meta-analyses that have shown a stronger effect of baseline severity. There have been some meta-analyses that show no effect of baseline severity. So I don't think that there's very strong evidence that baseline severity does affect placebo antidepressant differences. Thoughts on pharmaceutical company capture of organizations. I mean, obviously, I think this is, a huge issue. I'm just looking through studies that have looked at antidepressant withdrawal at the moment that were put together in that systematic review that was published, big systematic review that was published a few months ago by a German group. They're almost all conducted by the pharmaceutical industry. So how on earth are those studies providing reliable evidence on withdrawal? Of course, the pharmaceutical industry is not going to do systematic, well-conducted studies of the withdrawal effects of their medications. So we should be really, really skeptical about, gosh, it's really raining here. I don't know if you can hear. We should be really skeptical about, research data that's coming out of, that's produced by pharmaceutical companies.
There's a question, there's a DK David Krantz, I think, question. Please clarify whether you think that some people can benefit from drugs, and if so, how would you identify them?
So, yeah. as I tried to say and probably said a bit hurriedly, I think that I think some drugs, so I think antipsychotics can have some useful effects in people who some people who are acutely psychotic, particularly because they seem to dampen down people's emotional response and investment in their psychotic symptoms. They dampen down all people's mental functioning, but when someone's mental functioning is overtaken by psychotic symptoms, by hallucinations and delusions, having that damped down a bit can be helpful. And I think similarly for some people who have chronic psychotic symptoms, they can also be helpful. So I think that antipsychotics have a role for people who are psychotic. I also think that psychosis is, usually a really debilitating condition. So taking something that has adverse effects is more justified. I'm not convinced that antidepressants really have any useful role. Benzodiazepines are clearly very effective at alleviating anxiety and making people feel calm and relaxed. But there are problems with tolerance and dependence. So people, easily get into problems if they keep using them. So they need to be kept for short-term use. So yeah, I think it depends on the drug and it depends on the situation.
I think the time is a little past due, and many busy clinicians have got to go to their activities. You might want to stay on in case some people do stay on after the allotted time, so we can sort of free everyone, and thank Dr. Moncrieff for her most interesting and compelling presentation. Thank you so much.
Thank you. Thank you, David. Thank you, everyone.
I wonder if you just might want, in case we can see the number of participants, still some people remaining. If there's any questions that you can see, you could try to maybe read them and answer them at your leisure. Now, maybe there's one or two that you might want to tackle for a couple more minutes.
Yeah. Okay. So let's have a look. If medications don't help much, what's the alternative or a safe way to taper from medications? How about the use of lithium long-term? Definition of long-term use. Okay. Alternative to medication, it depends what the problem is. And this is one of the difficulties. We've got into this medical mindset where we think people have a disease and there's a treatment for the disease. People have lots of very complicated problems, and those need to be unpicked to decide what the alternative is. A safe way to taper from medications, slowly, gradually, particularly if people have been on them for a long time, and hyperbolically, so going down by smaller amounts, the lower the dose. In general, if you've been on medication for a shorter period of time, people can probably come off more quickly and more easily. Use of lithium, especially long term. So lithium, many drugs, I think, but lithium in particular, cause problems which include the precipitation of relapse when they are stopped. So there are several studies that show that you are more likely to have a relapse, an episode of your manic depressive condition after you stop lithium, particularly mania, than before you started it. Okay, so there's something about the process of coming off a drug that has restricted and slowed down your nervous system. And you can imagine that, the nervous system's in this state of rebound when you've stopped it, especially if you stop it suddenly. But even this happens even with fairly gradual reduction of lithium, that can precipitate a manic episode in particular. So my feeling about lithium is I'm not convinced that any drug actually really reduces the risk of relapse in people with manic depressive conditions, because no one's really factored in this withdrawal-induced relapse effect into the studies of long-term medication. And so I think the most sensible way to manage manic depression or bipolar disorder is to treat the episodes and try and help people to recognize them early and, you know, and contain people and manage people when they're going through an episode, and then helping people to come off the medication after it's finished. But if people want to go on to long-term treatment, because, you know, I do understand these episodes are really scary and they might want to, you know, try anything to try and reduce the risk of having a relapse, then I would try and discourage people from taking lithium, just because it's so toxic in so many ways. So I'd be suggesting some sort of low-dose antipsychotic. So
there is that. Do you see the last question on there? Are you familiar with the proactive study? Looked at relapse in 30 months in folks on antipsychotics, oral and injectable. Did you hear? I've heard of it and I haven't looked at the results of that.
yeah, no, I can't think what it is. I
Okay.
might know it, but I can't think what it is,
Okay.
I'm afraid. But thanks to Donna for highlighting it. Thoughts about the idea that people are spiritual beings, the bios, yes. I'm not a terribly spiritual person myself, but I think I've heard a few people say that a psychosis is a profoundly spiritual experience. And I think certainly for some people, understanding it that way is a very helpful way to understand it. So there's that. Then there's also organized religion, I think, can be, you know, very helpful at a social level for some people. And some people with depression and psychosis and all sorts of mental health problems. So yeah, that's my thoughts on religion and spirituality. How would I approach severe recurring depression with suicidal ideation? So, I mean, I don't think antidepressants are any more effective in really severe depression than they are in mild depression. In fact, if you look at studies of them in people who are inpatients with depression or who have really severe depression, their effects are actually even smaller than they are in general randomized controlled trials without patients. I don't think there is really any medical treatment that helps people with severe depression. I think we need to look after people, make sure they don't kill themselves, make sure they don't starve themselves to death, look after people patiently until they get better. And most people do get better from severe depression, unless it's a precursor to dementia or some sort of process like that. So, you know, so I think good care is what people need, and encouragement and companionship and that sort of thing is what people need when they have really severe depression.
Well, I think that about covers most of it all. I wonder if the organizers are interested to end the recording. I don't think I have the power to do that, or maybe they're on their break.
Well, I'm going to go because it's quite late
yes,
here and have my dinner.
yes.
So nice to see you, David.
So
Thanks
nice to
for
see
the
you,
intro
Joanna. I
and
hope
moderating.
all is well, and we'll be in
Yes.
touch. Take
Yes,
good
definitely.
care. Bye-bye, and thank you, everyone.
Thanks,
Thank you,
everyone. Thanks,
everyone.
organizers. Bye.